Good morning. First of all, thank you BOS and conveners for giving us this opportunity. I think all of us are practicing orthopedic surgeons. As my predecessors have stated, as orthopedic people, we always agree to disagree. Some people are using cemented, some people are using uncemented. Same holds true for the cup side also. And there is another block which is a hybrid fixation, cemented on one side, uncemented on the other side. So let us just come to some consensus how to go about. So as you know, total hip arthroplasty has evolved into a safe and cost-effective procedure. So why this fuss? I think revision rates are less than 5% even after 15 years. But I think we are planning to get these revision rates less than 5%.
Slides are not.
Slides are not going. 1 second, sorry.
Please check the.
Yeah. So it is one of the. It is called THR has been called as the operation of the century. We are almost approaching revision rates of less than 5% at 15 years. So why there is a need of this discussion? So I think as a practicing orthopedic surgeons, we strive to get this revision rate less than 2 to 1% even at 15 to 20 years. So I think all of us, the predecessors have said that Sir John Chanley in 1962, he revolutionized the THR surgery by introducing the concept of low friction arthroplasty. Initially, it involved cement fixation of the polyethylene cup, 22 millimeter monoblock head to improve the frictional torque. It's a concept of low frictional arthroplasty, so 22 millimeter head and a plastic. The long-term survivorship of Chanley THR is 95% at 10 years and more than 80% at 25 years. The initially implanted implants with first generation cementing in the hands of John Chanley from Wrightington. So initially, I think why there was a shift from cemented to uncemented, cemented cup to uncemented cup. Initially, the pelvic osteolysis, which was seen with the cemented cup, was found to be because of the cement disease. Means they thought it's a cement disease, the macrophages are eating the cement and that's why you are getting the pelvic osteophysis. So basically, especially the American industry, they started solving this problem by developing the uncemented implants and the uncemented fixation of the cups. Later on, as you all know, the osteolysis was proven to be an inflammatory reaction, basically to the polyethylene particles. And as Dr. Vaibhav had said, and even Dr. Panghate had said, highly cross-linked polyethylene has more or less solved this problem of wear, at least in the initial 5, 10 to 15 years. Because highly crossed polyethylene has a very low wear rate, and if you are combining a ceramic bearing with a highly crossed polyethylene, it is as good as ceramic on ceramic and a very low wear rate. The uncemented cups rely on initial fixation and primary stability with the surface characteristics of the aceteabular metal cups and secondary stability, which sometimes we put a couple of screws by the fixation. And the final sort of stability happens with the bone ingrowth, which happens on the surface of these aceteabular cups. So bone ingrowth is the formation of bone within the porous structure of the implant. It involves treating the cup surface with bed coating, plasma spraying or a tantalum porous coating, same like on the femoral side. The initial aceteabular cups, they had a threaded design without any surface coating. So that's why they had a good initial results, but later on they failed. Later on, threaded and expansion cups with grid blasted surfaces were introduced. Again, they had a very good short term, 3 or 5 year or 7 year mid-term follow-ups. But in the long term, at 10 years, they all failed because of the poor ingrowth and poor fixation to the native bone. So nowadays, I think the aceteabular cups, which all of us are using, are basically hemispherical cups with a porous coated surface and are most frequently used there. And they also have the flexibility of allowing us to put some of the screws if we are not very happy on table about the primary stability. But mind you, I think the uncemented cups, you need to have a good primary stability. Screw is just basically a whitewash, which we are actually satisfying our mind. So I think all of us are practicing orthopedic surgeons. We all know the advantages of the cemented cups. They offer on-table, firm, secure fixation of the cup, regardless of the quality of bone, especially in the elderly osteoporotic females. It can be used in elderly osteoporotic patients, useful in revision cases when there is a severe bone loss and where there is a cost constraint. Can be used in tumor cases. Disadvantages, initial few clubs and the traditional polyethylene, not the highly cross-linked polyethylene, had a high loosening rate after 10 years of implantation, high failure rate in physically active young patients. this is slightly a controversial statement because the Wrightington group, Videsh Raut and Robleski, they have shown excellent results even in young active patients with a cemented cup and cemented Chandli THR. Uncemented cups, advantages, a lot of pressure from the industry, supposed to be faster and quicker, shorter operating time, technical difficulties of cementing. Let's face it, a lot of us are now, especially the younger generation surgeons, they have not seen the cemented cups, so they probably don't know how to do the cementing, you know. Larger jumbo cups can be used in dysplastic hips or even in cases of revision when there is a big acetabular defects. Supposed to be better survival rate in young active patients. Purposefully said supposed because we'll go to the evidence-based medicine. Nowadays, I think all of us our practice is more or less dictated by the EBM, which is evidence-based medicine. They are supposed to be having a better survival rate, 10 years of implantation and preservation of the bone stock. If need be, if the patient comes for a revision afterwards, they are supposed to be sort of conserving the bone stock for the future surgery. Disadvantage, obviously they are costlier, a lot of pressure from the industry to use them because the cost is high and the margins are more. And their use can be tricky, as Dr. Pangate had shown on the femoral side. If you use these cups in the elderly patients with a porotic bones, and if you hammer or if you're not careful, you may blow away the acetabulum or you may blow away the posterior wall of the acetabulum. So let us look at this impassionately, you know, because as you know, which system to use is basically depends on surgeon's choice, experience, and how he is trained, and which system is comfortable. So excellent paper in the SICOT journal by these two French people, one Belgium and one French. And this is the paper, which I think it's quite good. So the aim of the paper is to cement or not to cement the acetabular cups in total hip arthroplasty. Fairly recent paper, 2019. They searched all the articles which are available in the literature. So see the studies, they chose almost about 12 studies which matched prospective randomized trials. 3,65,693 cups they analyzed. And what was the result? In every 12 of these studies, the cemented cup had a similar or lower risk of revision compared to the hybrid prosthesis. Forget about completely uncemented prosthesis. Hybrid is cemented femur and uncemented acetabulum. Though the functionality and quality of life was slightly better with hybrid prosthesis, especially in the younger patients. Survival was better with cemented cups. Functionality and quality of life was slightly better in the young patients with the uncemented or a hybrid fixation. And cemented cups were obviously cost effective. So I think I leave up to the best judgment of the audience what to use. So I think take home message, ultimately which cup to use depends on the patient characteristics, patient's age, quality of bones, surgeon's own experience and training regarding a particular system. The general consensus, which at least I follow, is that younger patients and physiologically young patients less than 50, 70 years of age probably go for an uncemented acetabular cup, whilst in elderly patients with a poor quality bone stock, it is always better to be safe and go for a cemented cup. I thank you for your attention.
Yeah.